Hello and welcome to Conversations with Dr. Bachner. It's Howard Bachner, Editor-in-Chief of JAMA. Once again, I'm pleased to be joined by Tony Fauci, Director of the National Institute of Allergy and Infectious Diseases and one of America's great public servants. Tony, long week for America. You've testified twice before Congress. You've been on a number of different shows. As of this morning, 49,932 cases yesterday. 642 deaths. What direction are we going in?
I think it's pretty obvious, Howard, that we are not going in the right direction. There are so many conflicting things going on right now. You know, we have areas of the country where they were at a level that was difficult and disturbing. Then when one tries to open up, even in situations in which governors and mayors were trying to abide by the guidelines of the different checkpoints, the gateway, phase 1, phase 2, that there is this, among some, not among all, there's this feeling of an all or none phenomenon where you're either a lockdown or you're just going to say, you know, the devil may care and just let it all go. And we saw that in the way people were congregating in crowds, which is understandable that people want to get out there, particularly as the weather gets so much better in different parts of the country. But it was done in so many respects at bars and at congregations without masks on, which is so highly predictable that you're going to get into trouble. And what we've seen as right now a very disturbing week. I mean, we had a few states, you know, Florida, Arizona, Texas, and California, where areas in those states together were about 50% of the new infections that we saw in the entire country. And what we need to emphasize to people is that even in those areas that are not showing a substantial surge, once you get surgences like that in some areas of the country, other areas become vulnerable because even though we're a very heterogeneous country, we are not without connection to each other. So the whole enterprise could be at risk. So we've really got to, and that was what I've been trying to do and emphasize at the hearings, that we're all in this together. You know, there's no blame here. There's none of that. We need to realize that if we do not adhere to the guidelines as we're trying to open, and I don't mean officially, I mean the citizenry, the people that are out there, we're going to be in some serious difficulty. Right now, if you look at the number of cases, it's quite disturbing. And we're setting records practically every day of new cases in the numbers that are reported. That clearly is not the right direction.
Tony, were you gratified to see some of the Republican leadership finally talk in a different way about masking? I was pleased to see it finally.
Yeah, no, very much so, Howard. I definitely was very pleased to see that. A realization that we've got to get away from any kind of implication of what it signifies. You know, it signifies one common good, and that is, care for the public health. I mean, there aren't many tools that we have in the sense of prevention. We don't have a vaccine yet. We don't have pre-exposure prophylaxis of anybody. So what we have are the public health things that we can do. And without a doubt, the kinds of things that you can do simply, like avoiding crowds, staying 6 feet, wearing a mask, it is very important to wear a mask. And I am very pleased to see, as you just mentioned, Howard, that now many of the leaders, regardless of what side of the aisle you're on, are realizing the importance of wearing masks.
I think also you tried to emphasize once again that wearing a mask protects other people. I still feel frustrated that it may offer some protection to me to wear a mask or to you, but you're really protecting your friends, your colleagues, the people around you.
Yeah. You know, Howard, I had mentioned this to you before in some of our discussions, and I think it's worth mentioning it again, is that it is understandable the differences of opinions and even in some cases confusion about the importance of protecting yourself, even though you may think as a younger person that the numbers, the statistics show without a doubt that as a young person, you are much less likely of getting a serious outcome as a person with an underlying condition or an elderly. But remember, first of all, there are many young people who have underlying conditions that put them at risk. Number one, risk of complications. And number two, you've got to realize that even if you get infected and get no symptoms at all, you are propagating the pandemic dynamic. Because you'll get infected, you may have no symptoms. The chances are you're going to infect someone else, who then will infect someone else, and then a vulnerable person will get infected. That could be a younger vulnerable person with an underlying condition. That could be an elderly person. That could be someone's grandfather or grandmother, aunt who has breast cancer and is on chemotherapy, a child with leukemia who's receiving chemotherapy. So you're not in it alone. You're not in it in a vacuum. You may feel like you're in a vacuum and say, well, if I get infected, who cares? I want to go have fun. No, you don't want to be part of the problem. You want to be part of the solution. And again, I don't want to seem that I'm blaming anybody, because it's not, because people are doing this innocently, Howard. I don't think anybody's doing it with a deliberate feeling that they may be part of the process that's hurting people. But you've got to remember, we're all in this together, and we have to take some societal responsibility. And that's the thing that I hope these sobering numbers that we're seeing are getting people to be jolted into realizing that not only we have the responsibility to ourselves, we have a societal responsibility to help put an end to this epidemic. And one final thing, I know I'm going on long, but I think it's an important message, Howard, is that rather than the mindset of their opposing forces, there's the public health forces and there's the open up the country, let's get back to normal forces. They're not opposing. The best way as a vehicle to opening the country in a safe way is to prudently use public health measures. So it's not public health against opening, it's the public health measures to help you to open. And I think we have to keep stressing that, as opposed to being opposing forces. No, they're complementary forces in so many respects.
Tony, there's a slight change in the ratio of cases to deaths. So as I said, 50,000 yesterday, 600 deaths. I look back, at the height of New York, Connecticut, New Jersey. Then it was about 30,000 cases and 2,500 deaths. So the ratio's changed a little bit. Are we doing a better job protecting the frail elderly? When you see that ratio change, what's your sense of it?
Well, I think there's three aspects of it, the way I think about it, Howard. And I've obviously been thinking about this very intensively.
Yeah.
Number one, if you look at the people who are getting infected now, there's about a decade and a half on average younger than were back then. So right away, the people who are getting initially infected are younger. Number two, you're correct. We know now how devastating this can be for the elderly and people with underlying conditions. So we are protecting them to a much better extent, protecting them better in nursing homes, protecting them better within one's own home. That's issue number two. Issue number three is that we better be careful, because it may be a secondary, tertiary, and quaternary before you get to the deaths going up again. So we may be seeing a delay. So I think it's A, younger people, B, we're protecting the vulnerable better, but C, be careful. As the weeks go by, we may start seeing the uptick of the deaths.
Yeah, I think I had Mike Osterholm on about a week ago, and Mike said, could you have me back in 2 weeks so I can correct all the things I said that may not have been right? I mean, he was so humble and just saying, I mean, he, like you, has been watching epidemics, pandemics for 30 or 40 years, and he's still learning a lot.
Right.
Tony, I just want to make sure I go through some questions, because I know people are interested. Pooling all of a sudden has come up, and pooling started with HIV disease. Could you explain what people mean by pooling and its implications potentially for schools and colleges? Because that's where it may be very helpful. But can you talk about pooling in terms of testing?
Yeah. So pooling is a phenomenon where you do it more for surveillance than to do things like individual people that you're trying to see if they're infected and do contact tracing. Pooling means that if you wanted to test everyone to see if they were infected, and you wanted to test maybe 10 people, you would use up the resources, the PPE, all of the material to do 10 separate testing. If you want to get a feel for the penetrance of an infection in a community, you pool samples, which means you take 10 samples. Instead of doing 10 separate tests, you take an aliquot of each and you do one test. And if those one test is negative, then now you've shown that there are 10 people that are not infected. You only use one test. If that test shows that it's positive, then you have to go backtrack and find out who that individual is. So if you have a situation where you have very low penetrance, but you want to make sure it's low, it's so much better to do pool testing than it is to try and do individual testing in the community. It saves resources, it saves time, it saves equipment, and it saves money.
Tony, you bring a few thousand people back to a college campus, and you think there's not much disease, but you want to test them once a week or twice a week. Is this a place where pooling may work?
Absolutely. It is more a surveillance than it is the kind of classical paradigm of individual testing, identification, contact tracing.
A couple questions keep coming up. Concerns about genetic shift. There's this reinfection with a second strain. Is there anything new about that? I know the data, Ann talked about data from the CDC. I'm sure it's also from the NIH. Much of the East Coast infected by Europe and China, much of the West Coast more from China. Anything about genetic drift or strains?
Yeah. There is work that's coming out now. It has been shown in some in vitro examination of mutations, a typical single mutation at a particular amino acid. There's a D614 and the D614G, which is what looks like, and again, there's some little dispute about it, but I think the data is showing that there is a single mutation that actually makes the virus be able to replicate better and maybe have high viral loads. We don't have a connection to whether an individual does worse with this or not. It just seems that the virus replicates better and may be more transmissible. But this is still at the stage of trying to confirm that. But some very good viral phylogeneticists are working on that right now. And it does look like a particular mutation may make the virus more transmissible.
Anything new with vaccines and bridging therapies? We talked about vaccines quite a bit, but anything new around the vaccine trials and the bridging therapies, monoclonal antibodies, hyperimmunoglobulin, convalescent plasma?
Since we spoke last, which was just a short while ago, Howard, things are moving along on track. A few of the vaccines now we have data on the phase 1 study of one of them, and the neutralizing antibody titers look pretty good. Always a caveat there, that's a big leap from what you see in a phase 1 study to what you're going to see as you get into tens of thousands of people tested. Vaccines going into phase 3 trial, end of July, others beginning in August, September, and October. Projection, as we said, that we may be able to at least know whether we're dealing with a safe and effective vaccine by the early winter, late winter, beginning of 2021. Multiple candidates are at different stages of development. So we're hopeful that one or more of them may actually show a good degree of safety and immunogenicity and efficacy, which is important, that we'll have a vaccine that might be available. Therapies, some good news. You heard about the dexamethasone for people on ventilators and requiring oxygen. Remdesivir showing a diminution in the time to recovery. Clinical trials now ongoing with convalescent plasma, with monoclonal antibodies, and with other agents that are primary antiviral agents. Like they're going into clinical trial. Hopefully within a reasonable period of time, we'll have a result.
Tony, if more than one vaccine becomes available, how will that get sorted out in the U.S. firstly? And then how do you think about the vaccine in the U.S. versus in other countries? Or if a vaccine, not one of the 5, is successful outside the U.S., how do you think through that?
Well, several of the manufacturers, the companies that are responsible, are making projections and already starting right now, some with considerable resources from the federal government in the form of BARDA, the Biomedical Advanced Research and Development Authority, where they're subsidizing them to start manufacturing at risk now. So several of the companies, I don't want to name them because there's all difficulties when you do that, are really promising that they would have a couple of 100 million doses as we go into the early part of 2021. And then after a year, saying they likely could get 1 billion doses. So when you have 2 or 3 companies, which you hope will be successful, they are going to be making vaccine not only for their own country, but availability in other countries. You know, there's this misperception that everybody's racing to be the winner. There's not going to be a winner. I would imagine from what we see that several of these vaccines are going to be very similar in their effect. And hopefully more than one of them will be successful. If so, we hope, as we should, that there will be some degree of equitable distribution so that people in a part of the world that can't afford it or don't do their own vaccine trial will have a fair accessibility to doses of the vaccine.
Tony, any new data, 100 people infected, the majority do develop IgG and IgM. I don't know what percent. The figures I've seen is 85, 90%. Do you have a sense of what percent are developing neutralizing antibodies and how long it lasts, or are we still in the development phase of the data?
You know, we're looking at that right now. That's a great question. And what is the difference? Is there any negative aspects of binding antibodies that, you know, in some respects interfere with the full function of the neutralizing antibodies? Right. That's being looked at very carefully now, and it will be looked at in the clinical trials as well as to the people who are recovering from infection. There are natural history studies that are looking at that.
Do you have a sense? You had commented, Tony, coronavirus occurs naturally and people get infected with it. Immunity from MERS and SARS has, the data are very limited, lasted 6 months, a year, 18 months. Do you have any sense from the data you've seen, or is it so preliminary with vaccines, about how long you'd expect immunity to last from a successful vaccine?
Yeah, good question. Because there is a big difference between the induction of immunity when you have natural infection and that virus is replicating in your system for a considerable period of time, and what you get when you use, you know, the artificial infection model, a vaccine. So we don't know how long it's going to last. We do know that there have been some reports showing the limited durability of detectable immunity in people who actually are asymptomatic infected, as well as those with symptoms. And I'm sure you've seen the data. It may have been in JAMA for all I know.
Right, I know. It's
it wasn't like years, but you don't know because you're only months into this process. So you really can't tell what the percentage of people who are going to have long range immunity. I mean, I think people sometimes forget, because we're so knee deep in this, that we're only 5 to 6 months into this right now. So any projections of durability of things are almost have to be projections, because we're not there with regard to real time.
Yeah, your first paper, our first paper on this was published January 23rd, 2026, Coronavirus Infections More Than the Common Cold. Authors Paulus, Marston, and Fauci. And so it's 5 months ago. That's all.
Right, exactly.
Tony, there had been struggles with the quality of PCR and the quality of serology tests. Are they better?
You know, in some respects, yes. We are now working, and I'm glad you asked that question, Howard, a substantial amount of resources, you know, to the tune of about $500 million is being given to try and develop in a RAD-X program, advanced point of care, sensitive, specific diagnostics of the like that we've done with other infections. And hopefully we will get a much better approach on diagnostics that are very, well, I mean, obviously a PCR is very specific, you know, and in many respects very sensitive. But how do you get it done in a way that's very rapid that you could scale up? That's what we really need.
I want to go to kind of big events. We have, and for the first time, we're seeing a lot of attention spent to the reopening of schools, kindergarten through 12th grade, colleges, and then you've made quite a few comments about sporting events, NFL, NBA. I'd want to give you a chance to clarify your comments about the sporting events, but can you talk about schools, colleges, and then go on to sporting events? You're widely quoted whenever you say anything, Tony. I will not cut you off.
I appreciate that, Howard. Thank you. So, you know, when you look at schools, there really is a delicate balance there, because obviously if you have massive outbreaks where you have an exponential elevation of a curve of new infections in a particular area, that you really don't want to have the kids go to school there. But we really need to be much more flexible in what we can do to get the children back to school, because just as a reflex reaction of closing the schools sometimes has some downstream effects that make things even worse for you with regard to home care, families, daycare, things like that. So a fundamental principle is within the realm of some prudent evaluation of the safety to the children and the impact on the community. We should try as best as possible to get the kids back to school. In certain circumstances where you get them back, but there's still viral dynamics in the community, there are a lot of creative ways that superintendents of schools are thinking about seriously about how you could mitigate the possibility of there being children being the vehicle of spread. Alternating days of classes, morning versus afternoon, the wearing of masks for children who are old enough to be able to understand what it means to have a mask, having capabilities of online for children who have underlying conditions that might put them at risk, protecting the teachers, making sure that they have the capability of not being part of an issue of spreading infections, so that you just do things in the school to mitigate it. But the principle should be, how can we prudently, with sensitivity to the safety of the kids, get the children back to school? A little bit different with the universities. You know, there are some creative ways that some of the university presidents are doing, such as, you know, test everybody once before they go back so you know what the baseline is, and then do intermittent screening to determine, is there anything under the radar screen? Maybe have a separate dorm so that when a person does get infected, they could go there if they're otherwise healthy and be sequestered from the rest of the campus or the rest of the university. There are a lot of things that are going on right now. I believe in a very thoughtful way how we can get the educational system somewhat back to normal. Bottom line also, Howard, to just get this in before we move on to the sports thing,
right,
is the issue of making sure that you make your judgment depending, particularly with the elementary schools, the lower education schools, not the higher education of colleges, that it's going to depend on the level of viral activity in the location where you're at. So we make sure we don't make any unidimensional statements like, in the United States, we should do this. Because there are going to be some counties, some maybe even some regions, where the infection is so low, there's absolutely no problem whatsoever with just making no changes in schools. And there may be other areas of the country where the viral dynamics is so intense that you really got to be really, really careful when you make that decision. So we got to be making sure we don't make blanket statements for the country and talk in terms of the activity in different regions of the country.
Sporting events.
Yeah, the thing I want to clarify, because we had a little discussion about this at the Senate hearing the other day with my good friend, Senator Rand Paul. And that is that, I mean, I do not make any determinations about what sport can or should be played. What I think got misinterpreted, a little bit confusion about quotes and things, is that I've gotten asked by anywhere from the commissioners in charge of a particular professional organization to the Players Association to the health people associated with different sports. And that's everything from baseball to football to hockey to soccer to, all the sports. And what I do is I answer questions based on scientific evidence and public health judgment. I don't tell anybody whether they should or could or might or not play a season or not play a season. And yet that has somehow, beyond me, gotten to the point that all of a sudden I've become like a gatekeeper for professional sports, which no way am I at all that. And in fact, as I mentioned to Senator Rand Paul when he asked me, I am not qualified at all to decide what sport is played and what sport is not played. They have very qualified people making that decision. I can only give to them my public health opinion about the current dynamics of the outbreak and the kinds of things that need to be done. The one thing I tell them all is that in their deliberations, they should pay special attention to make sure that they safeguard the safety and the health of the players and the people involved, as well as the spectators who are going to rely on the judgment of the clubs as to whether or not they're going to open up a stadium or an arena. That's all I ask. I don't make any judgments on what they're trying to do.
Tony, there's dozens of questions, but I'm going to stop. But I'm going to ask a couple of final questions. You've testified hundreds of times in front of Congress. You've advised, I think now it's 6 presidents, Tony?
Yes.
It was like a marathon last week. You told me it was over 5 hours. I felt like it was slow running marathon. What's been the most interesting testimony you've given to Congress? What if you rank order them? What are the 3 that either for good reasons or not good reasons? What were the ones that were so striking that you remember them to this day?
Well, I think they'd be in clusters, and the ones that were clearly defining were the very difficult years in the very early 80s when we were trying to figure out what was going on with what turned out to be HIV/AIDS. I mean, to testify before the Congress in such a moving target with so much suffering and pain and disbelief and stigma and things like that were going on. I think those early testimonies before the Congress, when you were trying to explain the kinds of things you would want to do when we didn't have drugs and we needed drugs, we didn't have anything at all. And yet there was such an intense need to get information out in a straight way. That was one series. The other one was following 9/11, when we had the Anthrax attack, when the country did not know at any given moment whether we were going to get attacked by a bioterror attack. And the Congress needed to know what we knew, and the intensity of that was most extraordinary. Another group is what we're going through right now. This is really unprecedented. I've been in situations when there were, and Ebola was another one. I shouldn't forget that.
Sorry.
We were going to get overwhelmed with Ebola, and I was trying to explain to the committees, the Senate and the House committees, that although we need to be very careful and pay attention to this, there was very little chance that you're going to get a major outbreak of Ebola in this country without lessening the impact that African countries were seeing. And then where we are right now, we're in a unprecedented pandemic, Howard. We haven't seen anything like this for the last 102 years in 1918. And this is something that we need to take very seriously because there's so many implications of it. On the one hand, you have people who are understandably concerned about the economy and how if we let the economy crash, there are going to be more deleterious effects on some people than others.
That balance, yeah.
That balance. And at the same time, when you're dealing with a very serious public health issue, and you don't want to balance lives against the economy, But I mean, you have people who think in one direction and those who think in the other. And you're trying to get people to understand that we're all in the same boat together. So let's get public health to help us to get the economy open, as opposed to two opposing forces.
Last question. So over all of these years, these 4 or 5 decades, Tony, did you have favorite Congress people that if they were asking you a question, you go, God, let them ask the next question? Did you have like favorite Congress people who you really enjoyed working with?
Well, that is dangerous.
Yeah, I know. I'm not asking the opposite. Only your favorites.
No. But the reason is, if I give, Howard, I've been there. I know this is going to get me in trouble, but I'm not going to allow it to, except to say,
okay,
what I will do is that excluding current members.
Okay, let's exclude current members of Congress.
Because I don't want there to be a comparison. But I mean, it was always a thrill testifying before Ted Kennedy. He was somebody with such a passion for the health and the welfare of the country, that even when there were times during the Reagan administration when he would be criticizing me as the representative, and I have so many great stories about Teddy Kennedy, where he would just rake me over the coals at a hearing because I was, quote, in the Reagan administration. And then after the hearing, when the cameras were off, he would come down to the table, put his arm around me and say, Tony, I love you. Nothing personal. It's just strictly business. And it was just, to have that kind of a person was just really extraordinary. And there were so many others that we had that was so important. Henry Waxman during the early years of HIV, he was such a passionate person, and on and on. But we're excluding the very, very good members. Current members.
This is Howard Bachner. I've been talking with Tony Fauci. I think people know who he is. He's really been in the American consciousness. And to everyone watching or listening, if you want to know what a true public servant is, you just have to know Tony Fauci. And Tony, there's some comments. Please convey our thanks. You might want to tell Tony he is our true Obi-Wan Kenobi. With that, I'll leave you, Tony. Thanks again. Good health. Stay well. And keep telling us what we should do.
Thank you, Howard. I appreciate you having me on your show, as always. Thank you.
Stay healthy.
You too, Howard.
Bye,
Take
Tony.
care. Bye.